Good morning. We are covering today the national guidelines on the treatment of tuberculosis infection that was actually published in February of this year, and has been probably one of the biggest updates and changes in terms of managing TB infection since, probably since the program was actually rolled out. So a proper guideline written purely dedicated to understanding and managing tuberculosis infection in the population here in South Africa. I'm going to put it a little bit in the larger context as well, and I'll show you a little bit about that on my next slide. This lecture is actually being broadcast live from the Family Medicine Boardroom as part of the Funda Fridays that we are having every Friday here in the Eastern Cape. So what I'm going to do today is I'm going to spend the first bit just focusing on the new guidelines, and I've also incorporated little details and aspects from the new adult primary care record of 2023 that's just come out. And we're going to be looking at how we assess patients for TPT, and we're going to look at the three major groups that's being recommended to get treatment. So our people with HIV, our TB contacts, and some of the other high-risk groups. But what has also happened, so this guideline came out in February of this year, but in June of 2021, after the WHO brought out their recommendations, the National NEML Committee actually did a costing on this particular recommendations. And there are challenges in terms of implementing the guideline in its full glory, so to speak. So we're going to look a little bit at costing and feasibility at the end, and that'll be good to have in a discussion to see what we can actually achieve within our current resources, and we can discuss that at the end of the meeting. So just a little bit of statistics in terms of why this TB infection is so much on the table. So the amount of estimated contacts, and this household contacts is an old term, but this is the term from the NEML report. We are estimated that there's about 104,000 people, and that is based on our TB incidence. So we roughly have, on our last TB stats from 2019-2020, we have roughly about 350,000-360,000 people every year that gets diagnosed with TB in South Africa, and that 615 over 10,000 is a very high incidence. And so if you look at the amount of households, that means the amount of people that can potentially be called a contact is just over 100,000. So in 2018 already, the United Nations, they set a target for TPT, and this is for a global target to try and get proper TPT coverage out there. And they were looking at getting about 30 million people covered between 2018 and 2022. We already passed that date. But at that stage, the South African target, they worked out at 2.5 million over that 5 years, which is about half a million people, potential contacts to be given TPT. So the TB strategy of the WHO has set very much targets in terms of us trying, we call it the NTB strategy. And if you look a little bit at COVID, we've sort of become used to TB being this ongoing endemic, but in theory, it's an infective disease. And in theory, if we brought the right public health programs, we should be able to actually get this endemic under control. And so there's an NTB strategy that says they want to reduce that TB incidence by 50%. And COVID has really made a challenge to us for reaching these targets. And we want to reduce TB mortality by 75%. So in South Africa, we have a 22% TB mortality rate, which is absolutely extraordinary. I mean, COVID has got a 1% mortality rate. And remembering TB is an illness we are able to diagnose early and we are able to treat. If you're diagnosed in time and you take your 6 months of treatment, you should not need to die from this illness. And so that 22% is very much an indication on terms of our public health program. And then what was interesting, just useful to mention here, in the National TB Prevalence Survey in 2018, they did this amazing survey to look at what's the actual prevalence of TB in South Africa. And so they went into targeted communities across the country, and they took symptom screening, and they tested everybody for TB. And they found that 57.8% of patients that did not report symptoms actually had a positive gene expert. So there's a concern that there might be quite a high incidence of subclinical or asymptomatic TB. So the guideline is based on what they call a TB test and treat approach. And there are three major groups that's discussed in the guideline. The first is all people living with HIV. And the major change you'll see today is we're now including children in that definition. So in the past, we only gave people with HIV sort of that 1 year IPT if they were over 15 years of age, but that has shifted. They also say in the guideline, but they don't elaborate on this, as well as each episode of new immunocompromise. And I find that interesting because it might be a useful way to think about patients, for example, who's defaulted their TB treatment for several years or a few months even, and now comes back with low CD4 counts, or patients who are failing and you're having to put them on second line. It won't make sense to actually give them another course of TPT. What we know with the TPT is it's most effective to actually treat your actual TB infection and while you're on it. So it's not going to protect you 2-3 years down the line if you have another exposure to TB. So the other big thing is then looking at all TB contacts to actually get cover. And again, at each new exposure. So every single time you're exposed to TB and a high exposure, we'll talk about that you get actually TB, a course of TPT. And then they do discuss other high-risk groups, but actually the guideline doesn't make very clear recommendations except for silicosis. So we will go a little bit through those, but they discuss the need to think in terms of our high-risk groups. I'm not going to cover this slide. It's just to show you basically the approach is very simple when they call TB test approach. At the top here, we have those 3 groups that I've mentioned. Evaluate for TB disease. If they don't have TB disease, you give them TB treatment, IPT. If they do have TB disease, you give them TB treatment. So the idea is that everybody gets something. You assess your patients. Some of them will get the TPT and some of them will get TB treatment. So then, of course, it's important to decide who is a contact and what do we mean by significant TB exposure. And the definition is basically you must have been exposed to a person with lung TB who has shared the same enclosed space. So that can be at work or socially or in a household setting for 1 or more nights. So even 1 night will be considered exposure. Or, and very important, for frequent or extended daytime periods. So remember, this is an enclosed space. So you'll have to take a really careful history in terms of how they're working and how they're spending their days to actually identify who would be classified as a contact. And we're looking at anybody who has shared space for that person in the 3 months before that index patient started TB treatment. So you can imagine if you had to take a proper history, you would actually probably find quite a number of people in the last 3 months, which this person might have spent, which might actually fits this criteria. So we don't actually like to use the term household contact anymore because it gives us impression it's only those people living in the household. So supposed to take a proper history and figure out who else might have been exposed. So just some other helpful definitions. For dosing purposes, basically they're using a cutoff of 25 kilograms, and those are usually children that's about 8 to 10 years old. You're usually already over 25 kilograms, but anybody who is over 25 kilograms, you will use the adult dosing charts. But if you're reporting in terms of children with TB and adults with TB, then 0 to 14 is still considered a child, and 15 to 19 is considered an adolescent. I'm not going to cover latent TB infection. Just to remember, there's a difference between having latent TB, so you're infected with the actual organism, but you're not yet sick, and TB disease. And the way we diagnose latent TB infection is using our MAN2 test, so our TST test, or the IGRA, which is available in the private sector, that interferon test. They do also have a definition, but I'm not entirely sure in which scenarios would be useful, which they call recent TB exposure, which is any contact with a person with TB in the last 12 months. So basically assessing this we know, so we can go through it fairly quickly, but there are certain people we're obviously not going to give TPT today. So anybody who's obviously got active TB disease, active liver disease, whether it's acute or chronic, and they specifically mention severe peripheral neuropathy, somebody who might have had INH in the past. If there's any history of them having had, obviously, adverse reactions to any of those drugs. And then they actually specify in terms of what we mean by excessive alcohol use when we say how much drinking is too much. So the idea is mainly drinking 5 or more drinks per day or more than 15, they call it standard drinks per week. So that will be the standard beer or standard glass of wine or standard shot of alcohol. And for women, they have a cutoff of more than 4 or more than drinks per day or more than 8 per week. And that's for both pregnant women as well as non-pregnant women. And then if there are abnormal liver functions, so these are not people who know liver disease, but the ALT might be up a bit, or the ALP or gamma GT might be up a bit, then they just recommend that there needs to be a risk benefit that needs to be done, and you can discuss those with an expert. So our symptoms for TB, and I'll check whether people have TB. We all know this. You're going to obviously screen for cough, for fever, for loss of weight. Very important in our children. That includes failure to thrive. You don't know if a child is problematic until you've actually plotted it on a chart. Our drenching night sweats, which is not so helpful in children. Hemoptysis will obviously make you very suspicious. And very important is that it's important now to look at also what is the history of TB, what's going on with their HIV, has the children had BCG vaccination, and that might make you more tempted to do further investigations, even if they're asymptomatic. So in children, we'll get concerned if there's also an isolated neck mass, any child obviously that's failing to thrive. And then for children, also important to remember, we can't use drenching night sweats, but a child is not playing, that's a worry. So if you've got a child who's not engaging in the normal childhood playiness, then you would also consider that a warning symptom. And in children, especially very small children, or immunocompromised children, they actually might come in quite acute. So it might actually look like a pneumonia or an upper respiratory tract infection, and do not forget the TB. And then very important, in pregnant women, we find that often they have a higher risk of subclinical TB. So that is why already the guidelines has already in the last few years recommended that we do a gene expert to screen all pregnant women. And if they are gene expert positive, even if they're asymptomatic, we would treat that. So in terms of examination of your patient, there's now a focus, which is a slight shift, that we're going to be doing gene experts on all of those contacts, for example, and you're going to try and get gene expert on any sample. So specifically mentioned for children, for example, that's also in the TB testing guideline, to do gene experts on stool. I still need to find out if our NHLS has actually got the capacity. They just usually have to know how to prepare the specimen. That's something I know that they're really pushing for in the future, because that'll be an easy way to get a sample on a child. People living with HIV, remember the guideline now tells us that we do a gene expert on every single patient at baseline. And I know we're not good at this because it's not in our habit, is doing an annual gene expert. So actually, when you write out that annual viral load for the patient, you should actually give them a bottle to bring in a cough sample as well for an annual gene expert. And that's certainly not something that's not quite in my habit life yet either. All contacts in this guideline is recommended to have a gene expert done. So that means somebody is going to have to make sure that every single person that's on that list of high exposure contacts gets a little bottle. And then the high risk groups, it's still not clear at which opportunities would you decide, for example, minors or inmates, on how often you would screen them, even if they're asymptomatic. So in the guideline, they talk about gene expert. In the APC, they actually talk about we're going to change the terminology to a TB-NAAT, TB-NAAT. Don't do it yet, because apparently our NHLS gets confused, but that's going to come, and that will become our routine. Then actually that gives the gene, depending on the history, depending on what that gene expert result is, the lab will then do other PCR tests. So for example, we do have an expert now for fluoroquinolone resistant TB. And so if there's rifampicin resistance on your gene expert, the lab can then go and do a gene expert for XDR TB. So your children, most children who are only over 25 kilograms, sort of over 8-year-olds, should be able to produce a sputum. So you're going to try at all costs to get a sputum from your children as well. And do remember sputum induction. The guideline still talks about gastric washings, but we actually know that there's much better evidence to do a sputum induction on a child to actually get a sputum sample. And that just means nebulizing the child with some hypertonic saline and then suctioning the back of the pharynx with one of those little mucus traps. But very worthwhile to try and all possible on these contacts to actually get a sample. If there are people who are living with HIV, with TB, and they do have TB symptoms and a CD4 under 200, we obviously have our urinary lamb as an option, but we won't be doing urinary lambs on outpatients that are asymptomatic. There's also a very strong emphasis on that if there's X-ray access, say you've got a household contact that's asymptomatic and not able to cough, there is an emphasis that if possible to try and get an X-ray. But it also says that the X-ray is not, you don't have to have an X-ray before starting TPT, but there's quite a push towards trying to get X-rays. Similar with children, though, if you don't have easy access to an X-ray and you can't get a sputum on a child and you can't get an X-ray on a child, that should not prevent the child from getting TPT. And of course, if you're X-raying a pregnant woman, then you want to protect the infant during that X-ray. There has been, in the past, we went through a small phase a few years ago where we were doing MANTU tests on people before they were receiving TPT. That has fallen away, and very, very clear emphasis that you do not need to test for TB infection before starting people on TPT. And that's mainly because in South Africa, we have something between 82 and 88% in our urban townships prevalence of TB infection. So, and if you're very, if your immune system is very suppressed, you might also have a false negative TST. So the TST doesn't actually become that helpful and is not part of any of the algorithms in this program. So let's just look at now what is the medicines we're going to use. And actually, we have a few options now, and our choices are going to depend on a few things. It's going to depend on the weight. So children under 25 kilograms can only have certain preparations. It's going to depend on the HIV status. So they are adding in some of the rifampicin, rifapentin preparations now into some of our possibilities. And that's an issue if somebody is on dolutegravir. So that gets a little bit more complicated. It's going to depend on the type of patient and the context. It's going to depend on the household and family. So the guidelines trying to make it easy. So the idea is that if you've got a household with all kinds of different people, try and give them all the same kind of TPT to make it look so everybody knows that they're all doing the same thing, just to make it easier for adherence. And it obviously depends on what other medications the patients might be on, and also depends obviously if you have the actual drug in stock. So the big thing that is very strongly recommended in this guideline, and I think that's what's really changed the landscape, and that's also why the WHO has brought in this very strong recommendation for all household contacts, is for the availability and the very good evidence on 3HP. 3HP stands for INH and rifapentin for 3 months, but what's amazing about it is that it's a weekly dose. So literally, you give them, it comes in a little blister pack, and in the one box there is 36 tablets that's going to cover that 3 months. And literally the patient gets their 3 months treatment in one go. So if you're talking about rolling out a massive TPT program, this is by far the easiest way to do it in terms of both monitoring and prescribing. So there's quite a lot of emphasis on that. If you can't use 3HP, and that's very much mostly in our younger children because we don't have the evidence yet, then the other option is also combining rifampicin and INH, so using Refiner, which we have available and is cheap, also just for a 3-month period, also good evidence. Of course, our major challenge here for our HIV positive patients is the rifampicin interactions with the ARVs. So it's actually not an option for our HIV positive patients. And then we still have the good old-fashioned INH daily for 6 months, and 12H, which is the good old-fashioned INH daily for 12 months. Those preparations we're very familiar with. So that's basically the 4 choices that we have. The preferred choice very much in the guideline is the 3HP, mainly because it is safe and effective, but it definitely has higher completion rates. And it has also been shown that it does have less risk of a drug-induced liver injury than with the INH preparations. That saying, both 6H and 12H does have very low rates of adverse events, although there's a risk of DILI, it's actually not that much. And people are always very concerned about INH resistance if people do get TB while they're on that preparation, but actually there's very little INH resistance, and the studies have shown that it's very safe to use. And of course, all of our patients, because there's INH in all of these preparations, will also be getting their pyridoxine. Good. So we're now going to go through each of the groups and see what we do for whom, and it gets a little bit fiddly because of the preparations. And we're going to start off with people living with HIV. So as I've said earlier, all people now with HIV is going to have that gene expert done 8 baseline, and everybody that's over 14 weeks old is going to get a course of TPT. And depending on their age and weight is going to depend on how much that's going to be. So in the past, remember, we only gave for adults 15 years and older. They got that here. Now, if you see a 5-year-old, 6-year-old, 7-year-old, you're going to put them all on that TPT. But what's also new is they also recommend what they call the TB test and treat approach after any new exposures. Say you've got a patient and you've given them their 1 year of TPT, and now it's 2, 3, 4 years later, and now their partner in their house, for example, gets TB. then that person actually qualifies for another course of TPT. They also mention this after each new episode of immunosuppression, which is not clarified in the guideline, but I can see it quite sensible if patients, for example, has defaulted treatment. So we no longer, I think in the previous guidelines, it was sort of, you gave this 1 year for one-off and then that was it. But this actually opens up the possibility to use it again when we think it's indicated. So there's a slight contradiction in the guidelines. There's like a table, and then what they say in the text is a little bit different. So one of our high-risk groups is people who's had TB in the past. It's got a much higher risk of actually developing TB again in the future. And so they recommend in the table that all patients who is HIV positive, if they've had a course of TB treatment, when they finish their TB treatment, you actually follow up with a year of TPT. In the text, they qualify it slightly, and they say that if you have bacteriological proof of cure at the end of that TB treatment, then you can give TPT, but only if they have had a significant exposure again, then you might give it. Or if they've never had a course of TPT before, then you will give it. So there's a slight differentiation here. If there's no bacteriological proof of cure at the end of the 6 months, they recommend you wait 3 months, and then at 3 months you assess them again on the same principles. Have they had an exposure? Have they had TPT before? But there's certainly, the door is open to just routinely give people the TPT for a year after they've completed their treatment. So pregnant and breastfeeding women, so that's the other change. So in the previous ARB guidelines, and this is also changed in the current ART guidelines, that the CD4 350 threshold has fallen away for TPT. And there's also, again, a very strong recommendation that we do not defer the TPT. So all pregnant women living with HIV, regardless of TB exposure, is going to be offered TPT, going to do that gene expert, work them up for TB, and breastfeeding is not a contraindication. So there are three standard treatment options for people living with HIV, and it basically has to do with the groups you're in. So our children who are under 25 kilograms, we do not yet have enough evidence for the 3HP, and there are more potential drug interactions with issues with the rifampicin, and so they only recommend the 6 months of INH, and you would only start it after 14 weeks. So the challenge with INH is that it kills off the BCG vaccine. So remember, all our babies get BCG vaccine at birth. And so if you put them straight on INH, then you would actually destroy the BCG vaccine. So the idea is you wait till they're 14 weeks old. So if you diagnose a baby at newborn that's HIV positive, you actually, and these are not TB exposed, we'll talk about TB exposed infants later, then you're actually going to wait till 14 weeks. They're still going to have their BCG vaccine at birth as usual. You now discover they're HIV positive, but they're not TB exposed, and you're only going to start that 6 months of INH at the 14-week visit. But once they're over 25 kilograms, so all adults and children, and if you are initiating them on dolutegravir, so this is a lot of our patients. We diagnose them with HIV. Now we're going to give them that 1 year of their INH, and so we're just starting dolutegravir. So if you're just starting dolutegravir for the first time, or if they're not suppressed on dolutegravir, then you're going to give 1 year of the INH like we've always done. But there's a proviso that if you've got somebody who's already on dolutegravir and the viral load is suppressed, or if they're on a non-dolutegravir regimen, I can't quite think who that would be, and then they could potentially get the 3HP. So then they can also have that easy 3-month, 1-weekly preparation. And they do recommend that you would wait 2 weeks before you would start your TPT after starting the ARVs. And then there's a little table in the guidelines in terms of your dosing for that weekly dose. Patients who are pregnant and breastfeeding, we have only got the option, we don't want to give them, add in the rifampicin, and so they all will be getting the 12 months, and most of them will be on dolutegravir anyway. And the same thing, you're going to wait a couple of weeks before you start that TPT. Right, so that's how people living with HIV. Major change, everybody's getting that routine course. So this is now we're going to move on to the TB contacts. And we've already spoken about the fact what our definition for exposure is. And of course, to be able to give all our contacts, we have to trace all our contacts. So all adults, adolescents, and children with significant exposure, contacts must be traced. So this is for our PTB patients. So we don't have to worry if somebody's got TB meningitis, for example, or got disseminated TB. But if you've got a confirmed positive gene expert on the from a sputum on the lungs, then you do need to find out who they might have exposed. And all of those people need to be evaluated for TB. So you'd be supposed to do gene experts on all of them. If they can't produce some sputum, sorry, not symptoms. If they can't produce sputum, you're going to do an X-ray if possible, even if they're asymptomatic. But they did mention in asymptomatic children, they don't want the sputum and the X-ray to become a barrier to the child receiving TPT. Because remember, a lot of these are household contacts. So they're all out in the clinic areas, and the clinics do not have easy access to X-rays. So we do not want all these children now to be coming to hospitals to have X-rays done. So it's only if you're on a setting where that is easy. And all of these people will now be offered TPT. Obviously, contacts might decline to take TPT, and then you're supposed to counsel and offer TPT at every opportunity. And obviously, you want to be screening them regularly for actual TB symptoms. So if we now look at contacts, we can start off with the newborns. And there's very specific definition on how we define a newborn as having been TB exposed. So it is anyone where the mom of the baby has been diagnosed with TB in the last 2 months, including obviously if she was diagnosed at birth, or the mom is on TB treatment, maybe for longer than 2 months, but there's a positive culture or a positive smear, recent positive culture or smear in the notes, or you've got a mom on TB treatment who's actually quite sick. She hasn't responded to treatment. So all of those would be TB exposed and will need some sort of cover. Very important, when the baby is born, we have to make sure that the baby obviously doesn't have active TB. And all of those babies, they recommend possible to do an X-ray, an AP, and a lateral to look for lymphadenopathy, and obviously to look for any other signs. And these children are quite systemically ill. So they might have low birth weights, they might not be feeding properly. You really want to look for liver and spleen, and possible enlarged liver and spleen, for jaundice, and any child that appears unwell, you're not going to give them TPT. You're going to send them to a center to make sure they get properly worked up. So the regimens we're going to use when we talk about newborns, there's different regimens depending on their status. So if you've got a baby who's HIV negative, so this is where the mom's had TB, the baby's negative, unexposed to HIV, that's what I mean with unexposed there. Those children, remember, we can't use the 3-HP, the weekly one, because it's not yet been, we don't yet have the dosing and the trials for children under 25 kilograms, although apparently it's coming. So you can use either 3RH, so that's the rifampicin and INH combination, the refiner basically for 3 months, or you can use the 6 months of INH preparation. But if the baby is HIV positive or the baby is HIV exposed, so they're taking nevirapine as part of their PMTCT program, then there's potential problems with giving rifampicin if they're on nevirapine or dolutegravir or lopinavir or ritonavir, which basically all the regimens we have for babies. So they will get the 6 months of prophylaxis of INH. If they're HIV negative children, so these are small children now, weighing less than 25 kilograms, but they don't have HIV and they've been exposed. So this was the old group, the under 5s, what we used to have. It's almost similar to them. We're going to be able to use the 3-month refiner option, which is still a daily tablet for 3 months, but it's a little bit easier than a 6 months course. And it's mainly being given because of the shorter course. And of course, there's a real emphasis for people, contacts who might have a weakened immune system and might be in that household. But of course, we are targeting everybody in that household. And there you can see there the dosing chart starts right from 2 kilograms, and they give the different options, and it's also possible to crush the tablets and disperse them in water. If the child is HIV positive and under 25 kilograms, we can't use rifampicin, we can't use 3-HP, so we're still going to use the INH for 6 months. So we're very used to the under 5s that's exposed, but you might have 6-year-olds or 7-year-olds that's also weighing under 25 kilograms in that household that's been exposed. And they will all get, either the 3RH if they're HIV negative or the 6H if they're HIV positive. So now if we look at contacts, so we still everybody in that household. So you've gone to the household, you've now figured out who the newborn is, you figured out all the little ones under 25 kilograms. Now you're going to have to look at all the adults within that household or within the work or social scenarios who's weighing more than 25 kilograms. And if they are HIV negative, So this is a new group. So we've never given before TPT to HIV negative patients. So if they're HIV negative and they're weighing more than 25 kilograms, then that's where this 3HP will become really easy, because you literally will give everybody their little blister pack with their 36 tablets. They all get the same thing. Everybody takes it once a week together. And that's the preferred option. Of course, availability is going to be the huge issue, whether we actually have this available yet. And so then we can give the 12 months of INH if we don't. In our HIV positive patients, the 3HP is actually also an option. And remember, though, these are HIV positive patients after exposure. So they might have had that 1 year of INH. The guideline wasn't very clear in what you do if you can't use the 3HP, but the way the tables work, if you read the way it looks like they're recommending the 12 months of INH, but this needs to be clarified. So they're not just recommending the 6 months post-exposure course. They're still saying 12 months in that guideline for contacts. So this might mean is they might have had 1 year now. Now in 2 years, they get TB, high exposure TB. Now they get a 1 year again of their INH. But they can have the 3HP if the viral load is suppressed. And then in our pregnant or breastfeeding women, so if they're on ARVs, this is also somebody who's had a high exposure contact. I think for most of our pregnant breastfeeding women, they'll be covered. If they're on ARVs, they'll be getting that 12 months of INH anyway. But an HIV negative pregnant woman who's had high exposure, we can't do the rifampicin, so they can get the 3 months of refiner or 6 months of INH. Great. So you might also, this is actually from the APC, the TB infection guidelines don't mention drug-resistant TB, but the adult primary care record specifically mentions what to do with household contacts of patients who are rifampicin or INH resistant, and they focus on INH resistance because, of course, now the nurses are the ones who's going to go out to their household and now screen everybody in the household, and they might very well have to follow up a patient. So if the patient is resistant to INH only, they've got INH monoresistance, then there is a recommendation in the adult primary care for 4 months of rifampicin. If the patient's resistant to rifampicin, so gene expert positive RIF resistant, then you obviously have to exclude TB, and you have to double check what actually that you have to look at what the index patient's actual LPA or results were. If the index patient, so the person the child or the person was exposed to, has got no resistance to INH, so they've got rifampicin monoresistance, then you can actually use the 6 months of INH as well. If there is resistance to INH or we don't know, then obviously you need to follow up with that index case. Is this XDR TB, do they have fluoroquinolone resistance? But they do recommend that all of those patients, so those patients who are both resistant to INH and rifampicin, needs to be discussed with an expert. And there are the rifampicin guidelines that also has recommendations for cover. They do recommend very strongly in all of these patients to do a chest X-ray. So because these patients, obviously you've worked up, the gene expert's negative, but they sort of, this is the case where you don't want to miss an underlying TB already there. And obviously if the chest X-ray is abnormal, you're not going to give TPT. And very much important that you want to send a sputum sample on all those contacts for what they call the TB NAT, TB microscopy, culture, and DST. We still call this the DR-TB reflex test. So at the moment, we would still do a DR-TB reflex on all those contacts, and you want to get them to a TB specialist quite soon to make a decision. Excellent. We are making good progress. So now the guideline talks about other high-risk patients, and they do have a specific section on silicosis. And they mention the fact that patients who have got known silicosis are at a high risk of developing TB disease, and they actually recommend that they get offered an initial course of TPT as well. So it's not clear, would you do this at diagnosis? What's more likely is we have patients with silicosis that probably never has had a course of TPT. So if you have patients with silicosis under your care, you would actually offer them a course of TBT. And very important, the same as all our contacts, every new exposure, you would do your TB infection treat. They also have a recommendation then also for those that have been on TB treatment, very similar to our HIV positive patients, that when they finish their TB treatment and they've got bacteriological proof of cure, that they also get a course of TBT. They do also mention that this is the one place where if they've got symptoms and you don't know is this TB or not TB, that a TST or IGRA might be useful, because if they're HIV negative and the TST and IGRA is negative, it means they've never been TB exposed. And then most of their symptoms are actually all HIV, it's all silicosis related. It can be quite tricky to assess these patients. And then you can use whatever options is available or useful for that person. So either the 3-HB or the 3-RH or the 12-H. And of course, 3-HB is the preferred option, and obviously with your pyridoxine. Then they have a paragraph on other high risk of TB disease. And actually what they say in the guideline is that it needs additional guidelines. So they make some vague recommendations, but they're talking specifically about inmates. So the question will be, in a correctional service, then how often do you then do gene expert screening, and how much IPT do you give? We don't have they also talk about healthcare workers, and that for me is a question. So they do recommend annual or maybe even biannual testing for active disease recommended. So all of us having a gene expert once or every 2 years. This needs clarity. And also, what do you do then if your gene expert if your gene experts say negative, do they then all take a course every night? That's not clear. I know one of the challenges with this, when I was at Nkqubela, I did have colleagues that every now and then you feel a bit worried, you do a quick gene expert just to check how you're doing. And then I've had completely asymptomatic nursing staff who then get a gene expert back that's positive with rifampicin resistant. And in those scenarios, we are not keen to put somebody on a RIF resistant. And what we always then do is we then do a TB culture. And because they're asymptomatic and they're not sick, I was quite comfortable to wait for that culture result before we would consider actually putting them on treatment. So it needs a bit of thinking through on what would we do if we were to screen, and then what would you give? Also, and this I'm not sure in terms of the evidence, some of the infectious disease consultants on some of our discussion groups has mentioned the fact that there maybe somehow it might be useful for you to have an active TB infection in terms of protecting you against future reinfection. So if you actually have TB infection, you've got like a massive high MAN2, you might be less likely, because your immune system is constantly activated, you might be less likely to get a new infection. And remember, our biggest risk of our TB flaring up is after a new infection. Your biggest risk is always after getting a newly infected dose of TB. So I don't know, this needs more research and more discussion before we start ourselves reaching for that 3-HB courses. Minors is also another group that is mentioned. And then also they do talk quite often about the immunocompromised individuals, certainly in terms of household contacts. I think all of these people must get coverage if you've got a household contact that is immunocompromised in some ways. But for example, diabetes is mentioned there. Again, we don't have a guideline yet. Do we do gene experts on our diabetics? Do we do TPT? When? For how long? Or, so at the moment, it's not yet in the guideline, but it's something that's recommended to consider. And then similarly, people who have had previous TB, there is some indication in this guideline, but to have very good clarity on what do we do with TPT for those patients. So just a little bit on the monitoring of our TPT patients. I'm going to go this quite quickly. This is the boring academic stuff. So our categorization, so a new TPT patient is somebody who's taken treatment for less than 4 weeks. So maybe you started the TPT and they defaulted, they're still new. But anybody who's had TPT for more than 4 weeks in the past will be considered a previously treated patients, and they've got outcomes. So they've got completed, obviously, and then they've got different definitions for loss to follow up depending on how long you were on your treatment. So for the short courses, if you miss more than a month, that's lost to follow up. 6 months course if you miss 2 months, 12 months course if you miss more than 3 months. You get treatment stopped and obviously died. And there's we'll talk about what we do in terms of how we manage loss to follow-ups in a minute. They've got some lovely apologies, I just realized that I got cut off. Can somebody please tell me where we were?
Madeleine, you literally just got cut off in 10 seconds.
Oh, sorry, just say
I said you literally, it was like 10 seconds, but I see Tandile Papuma is unmuted. If they could mute, please.
Okay. Actually.
Oh, sorry.
Just sorting out the screen. Apologies. Sorry, I'm just trying
It
to
was
figure
on
out.
your slide of follow-up.
That's fine. Yes, I assume my slide's gone. I just need to reshare. Here we go. The joys of Zoom. Okay.
Okay, we can see them.
Okay, perfect. Great. So
just slide view.
Yes.
Presentation mode. It's double sharing at the moment.
There we go. Okay. So we did the patient categorization. I assume so. Great. Jenny, yeah, just interrupt me if things are going wrong.
Okay, it's perfect now. This is the right slide.
Right slide. Perfect. Thank you. Great. So for the counseling, you're basically going to explain to the patient why they've been exposed, what's the benefits and risks. You have to explain to them how long they're going to take this stuff. And then what's quite interesting is they specifically mentioned that your 3-month course, your 6-month course, your 3HP. Sorry, that's your 3RH. Sorry, there's an R missing there. Your 3RH, your 6H, and your 12H. It's actually better to give on an empty stomach. I've never advised patients on INH to take it on an empty stomach, so that was interesting. And then 3HP is slightly better with a meal, but neither of these are train smashes, but it's the recommendation. You obviously want to tell them what, and especially if they're weakly, you're going to have to explain that quite nicely. And you're going to warn them, as we always do, of possible side effects. And the concern is always if they might develop a drug-induced liver injury. You're also going to have to talk to them about, we've already mentioned that too much alcohol with INH is not a good idea over a long period of time, also increases the risk of DILI. And of course, the smoking increases your risk of actually getting TB. So one has to have a chat about those. So for our follow-up visits, we want to actually see these patients as little as possible. So you want to monitor them every 3 or 6 months. And very important to align your appointments with any other scheduled visits or with their ART visits. So there's a huge emphasis generally in guidelines now. If you can give a 3-month bag of treatment, give a 3-month bag of treatment, whether it's now, no matter which course you are on. And if they're on one of the 12-month regimens, then you actually want to enroll them for the CCMDD and add it to their existing CCMDD drugs. Very important at every visit, obviously make sure that they don't have any TB that they've developed in the meantime. Do your ongoing counseling and talk about adherence. Check if there's any other need they have, and just checking on your side effects. And I think we're quite comfortable with all of that. So there's a few adverse events that we need to watch for, especially if we've got now lots of very well people on treatment. And the big worry is always drug-induced hepatotoxicity. So really the rate is very low, but we are giving it, if we're giving it to, well, 100,000 people, if we were to roll out this guideline, we are definitely going to see a significant number of people that might come in. So anybody who's got new onset vomiting or right upper quadrant pain, you're just going to stop that treatment, do your bloods and refer onwards. If patients if they've got severe peripheral neuropathy, then you can up your pyridoxine. Just a reminder that there's now a threshold of not going over 100 milligrams of pyridoxine, because actually high doses of pyridoxine also gives peripheral neuropathy. But if the patient, if it's not responding to the pyridoxine, if the symptoms doesn't disappear, then it's not worth it to give it. And you might have to stop the INH and consider an alternative regimen. Actually, gastrointestinal symptoms are quite uncommon. So if they do have, just make sure it's not a DILI. And you do get something on INH. I haven't seen this very often. I don't know if patients don't just complain about it, but it's in the books. There's something called the flushing reaction on INH. So this is a bit like getting a hot menopausal flush, a bit of palpitations, bit of headache, and you might have an increased blood pressure at that moment. And it's not actually dangerous. And it seems to be, maybe our patients are not big cheese eaters and red wine drinkers, because it has something to do with eating tyramine and histamine containing foods in combination with your INH. Sometimes you're going to get a mild itching rash. Both INH and rifampicin can do that, but that we can just treat with our normal cetirizine. And the worry is obviously if they get a proper allergic reaction, also very uncommon. So there's the classic hypersensitivity, you know, hives and fever within 3 or 7 days of starting your treatment. Obviously, you're going to have to discontinue the treatment until the reaction resolves and then discuss on whether the re-challenge is worthwhile or not. And you also get an hypersensitivity reaction that actually happens within 3 to 4 dosages and within a few hours after taking the medication. And this is particularly a hypersensitivity reaction to rifampicin. So it's a little bit different to sort of just the rashy one. It's more like flu-like symptoms, a bit more like the Abacava ones that we see, some fever or headache or dizziness. They might even have wheezing or muscle and bone pain. If it's mild, you can actually just manage the symptoms, but just watch out that they're not developing any severe complications like thrombocytopenia or hypertension, and you're obviously going to stop that rifampicin. We don't have much experience with rifampicin, so it'll be interesting to see if you're rolling it out to such big groups, how much of an issue that is. There's also a few drug interactions just to be aware of. So as we've mentioned with our infants and children, if they're on lopinavir, ritonavir, or nevirapine, then you can't use the rifampicin component reactions. And at the moment, we can't use the rifampicin if the patients are on dolutegravir until they're virally suppressed. And the only other interaction that's on this little table here that's important to note is that rifampicin decreases the levels of oral and implantable contraceptives. So that's actually problematic. So we're now going out with a very healthy population out there, and they need to be able to use barrier methods. Apparently the injectable contraceptive method is okay. So those on the Depo-Provera, that's not an issue, but those on Implanon or on the oral contraceptions, that might be an issue. And that's important to keep in mind if you're going to go and roll out 3HP to a whole household. What do we do if people miss? Tell them if they miss on the day, just take one as soon as you remember, but don't take 2 in the same day. If you miss your weekly one, to try and remember to take it within 3 days, and then they're quite vague. You can either take it on the next scheduled date, or you can take it weekly after that. It doesn't look like it's a train smash. And then they also talk about people who are defaulting. If they're missing less than a month on the shorter regimens or less than 3 months on the longer regimens, then you just include the missed dosages. But as soon as they've missed 1 month on that short regimen or 3 months on the longer regimen, then you will have to restart. And they do say if an individual interrupts treatment for a second time, so then you won't give again. So don't keep on trying. If they don't want to take it or they're not managing, then it's not worth it. So great. So let's just look at how much all of this will cost us. And it's the National Essential Medicine List. What they do is they get, there was a proposal that was put in to the NEML to put this into the EML. So this was a question that was asked. And so the question the NEML wanted to ask, what is the efficacy and safety of TB preventative therapy for reducing the incidence of TB amongst household contacts? So this is exactly this thing, and this is before this guideline came out. So they were still looking at the WHO recommendations. I'm going to read you what the final recommendation was. So the PhD Adult Hospital Level Committee, they did the research, and then they made a recommendation, and the NEMLC agreed with them that TB preventative therapy not be used for household contacts beyond the current national policy that recommends TPT for uninfected children under 5 years, exposed to a close contact of infectious pulmonary TB, or confirmed latent TB infection on TST. So I'm going to cover now why they made this recommendation, because this is in contrast with actually the guideline that we have. What's interesting is that some of the members agreed with the quality of the review. They agreed with the information, but they still thought that TPT for all household contacts would be great if it was possible. And I think this has to do with the golden ideal of this would be the ideal. This is really what we should be doing, is we should be covering anybody that gets exposed to TB treatment. But the biggest challenge is the cost and the feasibility, which is what they were looking at. So what they were doing, and this is in June of 2022, they searched for no, it was June 2022, because the guideline came out this year, sorry. So what they did is they looked at all the WHO guidelines, systematic reviews, and randomized control guidelines up until May 2021. And they looked also, they include a 1 month rifampicin INH combination as well that they were looking at. And what they found there, if you look at INH, so this is now INH in terms of all contacts. So if you've have had contact to somebody with TB and you take INH, so those are the 6-month or the 12-month courses, the number needed to prevent 1 case of active TB is 91. So for every 91 household contacts that we are treating, 1 person won't get TB. So that's our number needed to treat well. So it actually reduces active TB risk by 60%. That's the risk ratio, but the numbers needed to treat gives us a much better idea of the implementation of that. When they then looked at what is the difference in terms of the efficacy of these different regimens, actually, and the evidence is not great. So there's not a lot of very good head-on trials. And so they use the word probably because it's not great evidence, but it doesn't look like there's much difference in terms of which course you choose. So the 3-HP is definitely equivalent to the INH for 12 months, the 3 months HP. So that doesn't make a big difference. The other important thing in the research, which we do have some evidence on, is there was a trial where they tested INH head-on with 3-HP in terms of DILI. So we know for INH on its own that if you give INH, the numbers needed to harm. So for every 221 people that you give INH, 1 of them will develop drug-induced liver injury. So think back again to our 100,000 people that we want to put on INH. But when they had a head-to-head trial comparing the 3-HP with the INH, there was definitely an 85% lower risk of drug-induced liver injury because they're on such a much shorter, they're still getting INH, but it's only for 3 months rather than 6 months or a year. So there was 23 fewer cases of hepatotoxicity per 1,000. And again, that's quite significant if you look at huge numbers. So it's the cost that got tricky. So if you look just at the drugs, how much will it cost us to cover? And that 104,000 is the number they were using to do their cost calculations. So if you used INH monotherapy for all ages, so that's a 6 months INH for all contacts, that will cost us 18.3 million per year for that INH. If we use the 3-HP, using still INH monotherapy in the Littleys as recommended in the guidelines, then that will cost us 73 million. So the 3-HP purely from measure, 6 months of INH versus 3 months, definitely more expensive to use the 3-HP. But what's interesting is if you look at what they call total healthcare costs, because remember, if you're on 6 months INH, you're going to have to see those patients more often. And there are more programmatic issues in terms of how you run the programs. So the current standard of care, just for interest's sake, is costing us 19 million. So that's the total running of the program. Then if we were to put INH monotherapy for all ages, that will cost 167 million with all of those extra visits and sort of the time. And like they say, that cost is actually very difficult to calculate in terms of how much it will cost to actually run this program. But then actually the 3-HP comes out slightly cheaper or roughly the same in terms of, because it's programmatically so easy. You're literally just going to give them their 3 months and in one go to the whole household. So this is just a little bit, so this was the one set of information that made them look at, can we actually afford to do this? And then the other thing is the feasibility. So the WHO has got very specific recommendations that if you want to roll out a program where all households get it, you have to have healthcare provider capacity. So the healthcare workers has to be able to figure out, is this actual exposure? What is the risk of infection? What is the risk of developing active TB? Be able to understand when or when not you do latent TB infection. That's not relevant for this guideline though. Being able to weigh harm versus benefit of treatment, so being able to figure out who you defer and who you don't, being able to exclude active TB disease. So you need competent nurses on the ground. We just certainly have competent nurses on the ground. They're able to do this job, but we have limited resources in terms of the number of nurses to do this. The other concern that they highlighted is that the under 5s, at the moment, the contact tracing. So at the moment, we're supposed to contact trace all our under 5s. Only in 2019 and 2020, only 56% and 51% of those children were actually put on that INH. So we're not doing our current contact tracing program very well at all. The other thing is the level of evidence is only moderate certainty evidence. We don't actually know how much it will cost. So it's very difficult to do that information. And so the recommendation from the NEML committee is, rather than rolling it out to all the households, maybe we should focus on improving our treatment coverage, TB treatment coverage, improving our TPT that we're already doing for the under 5-year-olds, focusing on ART coverage, focusing on infection prevention and control, like we should be doing, and looking at the multisectoral interventions towards socioeconomic improvement of high-risk communities. So this was the NEML report, but just remember it came out before the guideline. So what next? What do we now do with all of that information? Firstly, there is recommendations that must happen. They are not only in this guideline, they're also in the ART guidelines. We must screen all our people living with HIV at baseline and annual with a gene expert. All pregnant women living with HIV must be screened and provided with TPT coverage regardless of CD4 count. In the guideline, in the new ARV guidelines, we are now doing TPT for all our HIV positive children over the ages of 14 weeks. So for me, that guideline stands, and we certainly need to introduce. We must upscale our contact tracing and TPT coverage of our children under 5 years and our children aged 5 to 14 that are HIV positive, and also for those TB exposed newborns. So let's at least do what we're supposed to be doing properly. Recommendations that we could actually do from this guideline with what we have already is actually, I think it's probably very sensible to at least do gene expert and, if possible, X-ray screening on all our contacts. So I think being able to identify that high exposure contacts properly and actually making sure that we do gene experts on all of them, even if they're asymptomatic, I think is a good start. And that should be within, we're already supposed to go to the households and screen contacts. And I think that we're supposed to be screening all contacts, but that can be done better, and to really up our game with that. Also, the recommendations for TPT for patients with silicosis in the guidelines sound sensible, as well as being able to be better at doing covering for exposure. So if you've got a high-risk patient that's been exposed to TB, like our immunosuppressed patients or even HIV patients to get re-exposed, doing TPT in those populations would also be sensible and can happen in part of our current programs. What's open for discussion is what we do at the moment for HIV negative patient contacts that are considered high exposure contacts, and that needs discussion. And it's a little bit to do actually with capacity, and it is a little bit to do also with access to having 3HP. So how able are we for whole households to give the 6 months of INH, and what is the implications of that? And then discussions, and that's also just for the future, is how we think about correctional facilities, inmates, healthcare workers, and those specific populations. Thank you very much, everybody. We have done a comprehensive look at the whole topic. I would like now to open it for any questions. Please, for those of you that are on the call, remember to add your names and MP numbers as attendance register in the chat. Can I ask for those that actually has entered before I was cut off to re-enter again, because I'm vaguely nervous that chat went missing. So please just put your names in there. I can see there are one person that's got a hand up. Maybe let's make a bit of a change and ask Noma Tandazo, here we go. Okay, let's open the floor here. Is there any comments or questions? Oh, yes, Noma Tandazo, great. What is your question?
Yes, I wanted to find out, I'm talking about pregnant patients. I want to clarify that one first. Now,
Yes.
I have 3 types of patients that will come to book. The one with the INH, of course. So this one is a patient that has been attending with me. And I do, she was here at Wellness in our clinic. So we know that we gave this person INH for 12 months, at some point, maybe 5 years ago, whatever the case may be. So for this patient, what is the way forward with regards to TPT now that she is pregnant? The second one is the one who is coming to us for the first time. She was attending her wellness somewhere else. And then she comes now to say, no, I was actually given TPT, but you don't have any proof. So how do I deal with her? And then the third one is the one she's attending with me. She was pregnant 3 years or 5 years ago, and I did gene expert and I gave her this thing INH for 12 months. So now that she's coming with this pregnancy 5 years later or 3 years later, what is the plan? And then also, I think I was just wanting to have some clarity. There are patients that maybe even with the last pregnancy 3 years, 5 years ago, that I may have initiated on INH, but there is no one, or there are no documents that actually can prove that she actually completed 12 months. Maybe she took 8 months, etc., or whatever the case may be. So that will be my questions.
You want to answer them?
No. The answer is there. You give the answer.
Yeah. So yes. So thank you very much. So the pregnant woman is similarly to all people living with HIV. That the focus is when you assess the patient. The focus is of whether they've had significant high exposure. So if you've got somebody who's never had IPT, they get the 1-year IPT. If they have not, I'll talk through the if you're not sure in a minute. So if they've never had IPT, then they get their 1-year IPT. If they've had IPT before and they are virally suppressed, so the guideline has got that little proviso of new episodes of immunosuppression. So if you've got somebody who's pregnant now, the viral load is suppressed, they've got a good CD4 count, they've had TPT in the past, they've got no TB symptoms, the gene expert is negative, you will not need to give them TPT again now. But obviously, you're going to check if there's been any significant exposure. What I think we want to do, it's a little bit to find that to be on the cautious side if you're not sure about history, to make a risk-benefit decision on what is going on at that moment in time. And you might have to discuss with a senior, because INH is fairly safe in pregnancy, but it's not 100% safe. That's why we had the CD4 count threshold during the previous one. So I wouldn't just give INH just to be on the safe side if I'm not sure about previous exposure. You might have to discuss and do a bit of a risk-benefit discussion with one of the doctors or one of the seniors. But the principle is if they've had their 1-year TPT, they don't get TPT again unless they've had a high-risk exposure in the last 3 months before you see them, if that helps. Doctor, any comments or questions from the family medicine department here? I think one of our challenges as a hospital is our struggling in terms of being able to do contact follow-up at all. And that might be quite a good discussion, because we quite often have patients with TB, and if they're very sick and very complicated, they might collect with us for 2, 3, 4 months, and sometimes for the whole 6 months before they go to the clinics. And we don't have at the moment a really good system on who actually, because what we should be doing is as soon as that patient is diagnosed, we should be sending people out to those households to do the screening. That's what we always should have been doing, and that's a challenge at the moment. So at CMH, we are at the moment in a process of really upping our game with our TB program in terms of recording, and that might be good to look at how we can link in to the systems out there. Jenny, yes, do you want to unmute?
Sorry, yes, hi, can you hear me?
Yes, lovely, thank you.
Thanks very much, Madeleine. Really very, very succinctly put. And I think also thanks for clarifying the areas of where there's a bit of ambivalence, because I think this has caused some confusion as different guidelines have been released at slightly different times. So I think you've clarified the areas of confusion very nicely. And I think that people can understand there are other guidelines or there's more studies, still awaiting. So yeah, just two comments. I think that the one was about the rifapentine. So we have received a donation as the Eastern Cape at the moment. If I remember, it was about 45 million rands worth. And so that is currently what we're using at the moment. And I think your comment about whether it's going to be available going forward I think it's going to depend entirely on donation. So I think people must be very flexible to say if they don't have it, they must just use one of the other INH options, because I think it is going to perhaps it's not going to be as sustainable as we would like. And the other comment was really about the contact tracing, and I think this is something that we've become a bit blasé about. And I was amazed, during COVID, how we were able to get contact tracing done, and yet for under fives we haven't managed to do it, and everyone's a little bit sort of, laissez-faire about it. So I think, if we're really going to change those statistics that you were mentioning earlier on, I really think we've got to put our heads into contact tracing. And it's difficult at a regional hospital, but even at our district hospitals, we need to start thinking, how do we make lists of names, send them through to sub-districts so they can contact clinics, or, can we submit to a clinic so that they can then start contact tracing? Even at clinics, we need to be far more aggressive about this, because I think, we realize TB really, really is a problem, especially amongst our children. We're seeing a lot of TB meningitis at the moment, with very poor outcomes. So thanks for emphasizing that. Thanks.
Thank you very much, Jenny. I'm very excited to hear. So I think I want to encourage, let's use the stuff. If it's there, let's use it. It's great if we have it. And I'll also check if we can actually get it here at CMH. I don't think we've ordered it here at CMH. I'll check with our pharmacists. But by all means, if there's a few thousand bottles lying around, I think we should use it and at least make a difference to those people that we can. And remember, for example, for our HIV positive patients who are already suppressed and needs a course of the 3-HP is an option. So it does make IPT much easier.
And then we are using most of our, I want to say almost all of our clinics have got the rifapentine at the moment.
Okay.
So
okay, excellent.
I know we certainly are having access to it.
Okay, well, that's exciting. Great. We'll make a plan at the hospitals. Any other fast questions from the room? Okay, so Dr. Adene is just going to have a word.
Mine is just to appreciate the presentation. I think you put it so succinctly for everybody to follow. But for the sake of our interns and students, especially my focus is for those TB exposed neonates. Specifically, I think we need a caution around that, especially newborns whose mothers have had TB treatment for less than 4 weeks. Those at risk of hematogenous spread or into the placenta, leading to the newborn developing what we call congenital tuberculosis. And essentially, they will present with a disseminated form. They may have hepatosplenomegaly on that, even at birth. And obviously, these babies are not going to feed well. Usually, they have mnemonic changes that will present within the first 1 to 2 weeks. And often than not, the placenta of that mother needs to be sent for histology. And if they present with a non-specific pneumonia after birth, in neonatal mothers have had treatment for less than 4 weeks, you must think of congenital tuberculosis. So very, very important that that concept is known. And for our colleagues in the districts, if you are diagnosing TB in a pregnant woman who falls into labor within the last 4 weeks, it's a concern for the baby. And therefore, such baby needs to be placed on proper surveillance by the attending clinician. Thank you.
Thank you very much. Yes, very important. I don't see any other questions in the chat. Please remember to put your names in the chat if you've not yet done so. Or if you've done it early in the day, same with you on those of you on YouTube. And yes, thank you very much, everybody. We're going to close the meeting here. This is our last meeting for the year. I think it's the last Friday for the year. Oh, there might be one next week. We'll find out. But no, next Friday is World AIDS Day. So CMH here will be celebrating World AIDS Day, and all the clinics and surrounding community is very much invited. Otherwise, we will see you next year, and have a very lovely Christmas and New Year. Bye-bye, everybody.
Bye. Thank you, Dr. Muller.
Bye. Thank you.